Well, welcome everyone to our Behavioral Health Transformation Public Listening Session series. And today we are going to be talking about full service partnerships. My name is Marlise Perez. I am with the Department of Healthcare Services as the Behavioral Health Transformation Project Executive, and really excited today to just present to you some of our thoughts around implementing full service partnership. Really wanting to hear your feedback today. So as our moderator mentioned, you'll be able to be providing that. We have 6 questions for you today, and we'll also talk a little bit at the end about how you can provide other feedback as well. So with that, we're just going to move through the slides. Already really touched on this a little bit here on what is available around tech support and other things. But if you have any questions, once again, just put in the chat and someone will help you right away. Next slide. All right. So just really, once again, the way our listening sessions work is it's really for us to present to you our thinking, but also mainly to hear from you. So we really, really want to hear from you. We'll be running through the questions and then going through some of the Q&A, some of the feedback we're receiving from you. And we won't hit all of it, but I want you to know that we're gathering all of it so we can use that in our decision making. Next slide. And so once again, we'll be gathering information. This isn't where we're going to be doing a lot of Q&A or anything like that. This is really just to hear from you today. Next slide. Another way that you can provide feedback is we also have a BHT info mailbox here that's on your screen. We will be looking for any feedback even after the meeting. You can provide that through November 6th. After that, we'll be putting together a summary document and posting that on our website. Of course, you're welcome to still provide us feedback after November 6th. It just won't be included in the summary document. Next slide. All right. So as most of you know, but I do just want to touch on really quick, with the passage of Proposition 1, it created the Behavioral Health Services Act. It also created the Bond Act. Today, we're just focusing on the Behavioral Health Services Act, and we're going to be focusing in on one of the provisions in that 90% of the county allocations, the funding they receive, and it's going to be around full service partnership. There are lots of other topics that we have been covering through these public listening sessions. So you're welcome to check those out on our webpage. There's information about those. And we also have another one coming up on November 11th, which is going to be November 4th. Sorry about that. And that's going to be focused on our behavioral health services and supports. But today we are just focusing in on full service partnership services. Next slide. All right, so as we've already talked about a tiny bit on that other slide, 35% of the county's allocation of funding must be used for full service partnership programs. If you're familiar right now with our current Mental Health Services Act, you'll know that full service partnership is a whatever it takes. So really working with individuals to provide that care that they need. We're going to talk a little bit today around how this has transitioned from MHSA into BHSA. And one of the main areas is this is the first time that we have a bucket of funding dedicated to full service partnership. You'll see here it's outlined in our Welfare and Institution Code. Here's the citation there. And that there is an opportunity for our small counties to request some exemptions. We'll talk a little bit about that later as well. And counties also do have some flexibility to move funds around based on local need. Next slide. So this is directly from the law, from the statute. And so this is all of the kind of high level information pertaining to, I'm just going to start calling it FSP just for my sake, but full service partnership. And so of these areas, I do just want to highlight the first is that counties can utilize these funds for mental health services, supportive services, and substance use disorder treatment services. But what we're going to mainly focus on, and you'll see here, they can also use it for outpatient and engagement services and other areas as well. But what we're going to focus on is really diving into these newer areas that are under BHSA. And these are around evidence-based practices. And we're going to go through each one of these today. I do want to highlight as well around this assertive field-based initiation. We've talked a little bit about this in our listening session around substance use disorders, so you're welcome to go and take a look at that as well. Next slide. All right, so for FSP, there really is a continuum of what is, really beneficial for individuals. And so we have here the required services. So all of these services here, these are outlined in statute and must be included in the FSP programs. This is everything that was just listed on that other slide as well. And once again, we're going to go into detail on a lot of these pieces today. There are also other allowable services. So those include having a FSP model for individuals that have a primary diagnosis of a substance use disorder, could also be additional evidence-based practices, outreach and engagement, and then other non-clinical services. I do want to note as well that the statute lists housing interventions, and while we are definitely wanting our folks to be receiving housing interventions, there is that separate 30% bucket of funding for housing interventions. So those services would be funded underneath that bucket. Next slide. So integrating with substance use disorders, as most of you know by now, that was one of the big shifts from MHSA into BHSA. And so for, as we're talking about, well, what's the expectation around substance use disorder services in FSP, is counties must be conducting assertive field-based initiation. So you're going to see some requirements around that. And then FSP teams need to be capable of supporting individuals that either have a co-occurring, so they may have a mental health condition and a substance use disorder, or just a standalone substance use disorder. Next slide. All right, so we are already at it here. Just want to open it up for feedback. So what are some effective models or service components to integrate substance use disorder into FSP teams? So if you could put your comments in, and we will start just going through them. And once again, we're going to start reading them. We won't be able to read all of them, but we are collecting all of them. All right, so we're starting to get some feedback in. So we're seeing field-based medication-assisted treatment services. Also having staff that have lived experience. That's an effective model. Also having hiring alcohol and drug or SUD counselors, making sure that you have those specialists on your team. Seeing a lot around that. So, and that actually encompassing registered and certified. Also, seeing a lot around having multidisciplinary teams. So that would be having mental health providers, substance use disorder providers, peer support specialists, and case managers. And that is just to have comprehensive care that address the complexity of co-occurring disorders. Also some having like incentives for behavioral health practitioners. Uh, Also some flex funds for clients' needs, to make sure they have that the case managers have. Um, Also a 15-to-1 client ratio, client to staff ratio, strong field work, and after-hours capabilities.
There's also
Lots
a
of
suggestion of adding harm reduction services into FSP teams.
Yeah, also seeing just a lot of comments in about the importance of peer specialists and a lot around different types of training to make sure that there's training for the teams that are out there. One example was like around motivational interviewing. Seeing a comment around the expanding the SUD system navigation programs to be more field-based, especially at interim housing sites. Lots of great comments. A lot are coming in pretty quickly, so thank you so much for that. Um, I think this will just be the last one I read right now, but employment services for clients are important for getting clients occupied and using, having those abilities to have those services. So feel free to keep adding them in the chat. Once again, we will, or the Q&A, excuse me, we will be collecting all of those. But I am going to move us forward into our next topic around assertive community treatment and forensic assertive community treatment. So these are both evidence-based models. And so for ACT, individuals need to be 18 years and older, have a diagnosis of a serious or persistent mental illness, and have significant functional impairment, and then also have an indicator of continuous high service needs. So this is really an evidence-based practice for individuals that have that high level of need. And our proposed ACT eligibility criteria is based on the SAMHSA, which is our federal partners, a Substance Abuse and Mental Health Services Administration, their toolkit, but we also looked at criteria from other states and then worked, of course, with our internal partners and experts in California as well. Next slide. So these are the service components for ACT. I do just also want to state, for those of you that are familiar, DHCS has submitted a waiver to our partners at CMS. It is a Medicaid waiver called our BH Connect waiver. And our alignment with FSP and the BH Connect waiver are like this. And so for our county partners that are opting into that waiver, they'll be providing the same service components for ACT and FACT, as well as underneath BHSA. And so in relation to that, these ACT programs must mirror those service components in that Medi-Cal benefit, like I just mentioned. And then they need to be made available to non-Medi-Cal members who are, receiving services and of course qualify and are eligible under FSP, and of course eligible for that clinically necessary level of care. The funding can also be used to cover additional non-clinical supports that are not covered by Medi-Cal as needed. Next slide. So what we are doing, because an evidence-based practice is only as good as it, being instituted and making sure that it's done to what's called fidelity. So we are going to be having fidelity monitoring, certification, and training at DHCS. So we're partnering with a Center of Excellence to provide this type of fidelity monitoring certification training, not only for ACT, you're going to hear me state this through the rest of the FSP components as well. And so our FSP Act programs are also going to be required to meet these standards around certification and that fidelity monitoring that we are going to be putting forward as this continues to roll out. Next slide. So ACT is for general population adults. What FACT is, that is tailored to individuals that are justice involved. And so the way that the counties can put together their FACT teams is really going to be based on what do they have available locally, and then obviously what kind of needs do they have. So for our counties that may be larger or may have a larger justice-involved population, they may choose to have a dedicated or more than one dedicated FACT team. But our smaller or rural counties may integrate FACT within their current ACT team. And the ways that they could do that is they could have an ACT team member that has lived experience around justice involvement, or all of the ACT team members could complete the FACT training. So there's different ways to meet this requirement around FACT, and it really is going to depend on the local need at the county level. Next slide. So here we are, need some feedback. So for FSP teams that are currently implementing ACT and or FACT, are there lessons learned that can be shared or resources, supports that would have been helpful when you were doing an implementation? So just going to open that up for feedback now. So if you could type that into the Q&A, and Tracy and I can read out some of the responses we're receiving. Just waiting for some feedback. We do have some comments around this individual says, need a strong model for what to do if teams end up with more clients than meet the ACT ratios of client to provider. This person asks around like, should all FSP teams be implementing an ACT model? So that is a requirement that we would be requiring counties to have an ACT model, yes. Okay, so we're not getting a ton of comments in around the question, which leads me to believe that there aren't a lot of counties that are currently implementing ACT or FACT, or at least they're not with us here today. Oh, we have some comments and that are just starting to come in. Integration and cross-training of peer support specialists with the CHW provides a workforce with a skill set that can care for individuals with complex comorbidities.
We also have a comment about having a strong relationship with the court or mental health court being critical.
Um, this comment is, I'm guessing probably more from someone in a rural area that remote work is challenging, in that do whatever it takes because when there's a crisis and providers are remote. So it sounds like getting to those individuals is a challenge. Another about having low case manager to client ratios, um, less than 1 to 15, flexible funds for clients, after hours support, employment support, nursing supports for substance use issues, and long acting injectables.
We also have some feedback that training on trauma-informed care and harm reduction, crisis management. So individual roles and responsibilities aren't siloed.
Mm. Another one here also making sure that they're like the staff are able have the capability to do field work. Just more about the importance around having those peer support specialists involved with ACT and FACT as well. And with that, I'm actually going to move along because we have a lot more material to provide you and also more questions for feedback. But please feel free to continue to put in the Q&A if you have any feedback to that last question. So the next area I want to talk about is intensive case management. So we can move to the next slide. And so, intensive case management, which I'm just going to abbreviate now to ICM, it is well-known service. It's documented in a lot of literature. It's really that comprehensive set of community-based services. And so really, it's what a lot of our FSP teams are doing now when they're doing the FSP services under MHSA. Now, there isn't a set fidelity criteria like ACT has, but generally ICM is really taking those principles of case management and then having, lower staff to client ratios, assertive outreach, and direct service delivery. Next slide. So if individuals are receiving that FSP ICM, it really could be individuals could be coming in at the level of just needing that ICM, or maybe they've been receiving ACT or FACT and they step down into ICM. Of course, that step down would be determined, clinically, have a clinical determination. There could be instances where someone's receiving ICM and clinically they need to step up. But it really is meant to have that ability. And so individuals, once again, it doesn't mean that they start an ACT and everyone starts an ACT and moves down. It's nothing like that. But it really, individuals that are 18 to 26 or are younger, they may also be determined clinically that ICM would benefit them as well. We're going to talk a little bit later about different evidence-based practice for children, but maybe it is determined that this individual would benefit from these services and they could receive them as well. Once again, if that's clinically determined. Next slide. And so just kind of, and I saw some questions in the chat and I'm hoping this will answer some of your questions of like what's kind of the difference between ICM and ACT. And so once again, these are in orange here, these are our proposed ACT requirements, and then in blue, ICM, and then in black is really where they're both meshing together. So you're going to really see here a lot around the severity of their condition. You're going to see, that is where there's a big difference in the level of care that they would receive there. Also, just any kind of indicators of continuous high service needs, and you'll see examples of that as well. So once again, this is going to be a clinical determination of what the individual needs, whether they need ACT or ICM. Next slide. And so we are developing guidelines for, as we're putting this together. It is, once again, we're going to have these guidelines out in policy, but it's really going to be up to that team and that clinical judgment as to determine what level of care is most appropriate for the individual. As we've talked about, they may be moving between levels of care. We are going to be having, that fidelity and that training and technical assistance provided. And then we'll be really focusing from the DHCS lens when we're looking at the monitoring to ensure that all of these FSP services and components are available, including the FSP levels of care. Next slide. So these are what we're proposing as services for ICM. And once again, these services, they may need some of them, they may need all of them. It's really going to depend on the individual. And we do just want to highlight that this list is not an exhaustive list. Additional services may be provided on an as-needed basis. We also just want to recognize that the importance of, with ICM, but also with ACT and FACT, that pairing with housing is really important. Once again, that would be funded under that housing interventions bucket, but it really is a recommended best practice. Next slide. All right. So what other components should be looked at when serving individuals under ICM? So if we could just move back one slide so folks can see those service components that we have right now, but what other service components are important to consider in this service? So if you could put your comments in the chat, excuse me, I keep saying chat, in the Q&A, that would be great. Thank you.
We have a suggestion to include occupational therapy.
Also, field-based for unhoused. Substance use counseling.
Including harm reduction supplies and support. Trauma-informed care and support, and then inclusion of medication-assisted treatment for those that have SUDs.
Contingency management model for SUD. Client-centered strength-based approaches. This comment is actually for ACT, FACT, and ICM, but additional supports, including flexible funding for items related to gaining employment or going to school. Basics like clothing and food are often critical for engagement.
There's also a couple suggestions, one for transportation assistance and another cultural brokers as needed, including ACEs screening to identify child adverse.
Also, community integration. Yeah, just more around community integration, focused services, helping people find and heal in their community, hobbies, friends, etc., a network outside of service providers. And with that, I'm going to take that as the last comment that we're going to read aloud. But once again, feel free to keep putting in the Q&A any comments you have on that question. Next, I want to move to supportive employment. And I know some of you have already been talking a little bit around the importance of employment and focusing on the individual placement and support. So we're going to talk here about IPS. And so IPS is a model that has been very effective. It's a very strength-based approach to helping individuals that have a serious mental illness find and maintain employment, which, as we know, is really important for individuals, maintaining their recovery and integrating back into the community. So supportive employment can be integrated into these other FSP services that we've been talking about so far with like ACT and FACT and ICM, but also with high fidelity RAP and coordinated specialty care. And so once again, just really helping provide that comprehensive support to individuals. So this supportive employment programs are going to align also and mirror the Medi-Cal benefit being developed through BH Connect, like I mentioned earlier. And then once again, just with IPS, it really is shown to demonstrate higher rates of competitive employment for individuals with behavioral health disorders. Lots of literature here that we've also cited if you want to learn more about IPS as well. Next slide. And so this model, if you're not familiar with it, it is a part of psychosocial rehabilitation. So it's really providing that structure and support, that connection to reduce isolation for individuals with an SMI. It's designed to help individuals find and maintain jobs as a part of their recovery. And it's based on these 8 core principles here that we have on the right. I do just also want to highlight, it's not just getting that job service, but it's also like even that pre-work prior to the individual even applying for a job. And I think a real important principle of this model as well is that it's zero exclusion. Next slide. And so the criteria that we're proposing to be eligible for this service is, once again, they would have to meet the eligibility for FSP, but also that they express an interest in supportive employment services. So once again, it really is kind of back to that zero exclusion criteria that I was just mentioning. And there's more information about that as well. And we have a link here on the IPS fidelity scale, but also that eligibility is based on that consumer choice. That's a really important piece of this as well. And we have more information on that in this SAMHSA toolkit here cited on the slide. Next slide. And so the service components that we're proposing is first is kind of what I already talked briefly about around pre-employment services. So once again, this is really helping get that individual ready for employment services, and you'll see some examples that we've highlighted here. But then also having employment sustaining services. So really helping them manage their employment along with their behavioral health condition and any sort of challenges that may come up during that process. You'll see some examples here around such as career advancement, maybe job coaching, and other supports as well. So are there opportunities for counties and providers to partner with local entities to implement IPS. And then I also just want to kind of add in for those that have been doing IPS, any lessons learned that you would like to share. So if you could place your comments in the Q&A, that would be great. Thank you. Okay, we'll just give it another minute. We're not getting much feedback yet. But once again, if you don't have feedback today, but you think about it, in the next few days, would really love to hear your feedback. So feel free, you could always send it to our bhtinfo@dhcs.ca.gov mailbox, and we can look at it then. Oh, after I said that, we got a whole bunch of feedback in. So it looks like seeing some feedback around partnering with the Department of Rehabilitation to provide employment supports with individuals with disabilities. This comment, they have collaborated with Workforce Partnership to provide paid internships for justice involved, peer support specialists who are being cross-trained.
Also, a suggestion about partnering with community colleges that have resources like career counseling and vocational training programs. Counties can leverage these educational pathways for IPS participants.
Also, the provider and the service recipient understanding the benefits and impact on eligibility of continued benefits. I think that's especially important when related to SSI. Also, for individuals that may be in recovery from a substance use disorder, perhaps looking at becoming a peer counselor or an SUD registered or certified counselor. Great. Well, feel free to keep putting input in there. I am going to move us on because we still have a few more questions to get through in slides, but please continue to respond to that question or any others as well. But next, I want to talk about high fidelity wraparound, which HFW. So we can move to the next slide here. And really, high fidelity wrap, we have been doing these services in California. They may not have or may not currently be done to fidelity, but we're looking at instituting this in the FSP model. And what this is, if you're not familiar with it, is once again, it's a team-based structure, but also integrating the family involved in this as well. And once again, it's that anything necessary, kind of whatever it takes. But this is for our children and youth. And this is for our children and youth with the most intensive mental health or behavioral challenges. And so this really is a model that can be an alternative to out-of-home placement with children with complex needs. And so what this does is this model really puts at the center the family voice and decision making in developing that care plan for that children or youth. It's really having that structured set of strategies that are it's going to result in services that are really making sure that it's relevant to the child, youth, and the family. It's delivered by a high fidelity RAP facilitator, and they're the ones that really lead that team through this process. While there is a structure to it, it's also very flexible and responsive to the child and the family's needs. And so there's really, in this model, there's these 4 phases. The first one being engagement and team preparation, plan development, implementation, and then transition. Next slide. And so really there is, once again, this is an evidence-based practice, and that really the results have found that programs that are implementing this and practice to fidelity really have better outcomes, such as the child's behavior and the parent satisfaction, the mental health functioning, reduced absences and suspensions from school, and also cost savings. We do have a lot of links here to research if you want to learn more about this evidence-based model. Next slide. So for FSP, we are requiring the high fidelity RAP, but once again, this is also linked to our Medi-Cal benefit. And so you're going to be seeing a lot more coming out from the department around high fidelity RAP for our Medi-Cal lens. And so once again, this will be in our FSP model, but it also will have a corresponding Medi-Cal benefit as well. And once this is something we are continuing to develop guidance on for that Medi-Cal benefit, and you'll see more of that guidance and those discussions happening over the course of several months. Next slide. So how are counties and providers that are currently providing high fidelity RAP services aiming to ensure that these services are moving toward fidelity for BHSA, so under FSP? Are there specific areas of TA, technical assistance, that are needed? So going to open it up again. If you have any comments or feedback that you can place in the Q&A for us. Some comments are coming in that children's providers would need training on high fidelity RAP on that model itself. And then actually the next person has a question about that Centers of Excellence, and they would be providing this training. So that is one way that that training for high fidelity RAP would be provided for providers and also county partners. TA around the standard outcomes for the assessment based on the fidelity model.
We have another suggestion that having mandatory in-person training is a core tenet of the wraparound model.
Also some
Another
comments. Oh, so go right ahead, Tracy.
I was just going to say another suggestion, making sure that peer organizations are aware of the benefit and training opportunities.
So just some questions in here, but I'm just going to kind of rephrase as a comment to ensure like which high fidelity RAP model is being used. There's the RAP Fidelity Index and then the team observation model. to measure the fidelity. So being clear on the model. Great comment. Great. Just other comments are coming in around just kind of echoing the importance of having in-person training. And once again, through that center of excellence. And with that, I'm just gonna, because we're starting to run out of time, I apologize, but I'm gonna move us forward. Feel free to keep putting any comments in to the Q&A if you have other comments around that. I do next want to talk about the adults' FSP levels of care. And so there are requirements in BHSA to have levels of care for full service partnership. And so what we are proposing is for adults, we are proposing that ACT would be the highest level of care. As we talked about, that is the most intense. So that would be ACT in fact as being the most intense level of care. And then having a step down level from ACT, and that would be the ICM that we discussed. Once again, could be movement between those levels of care. And so the definition of adult would be for those that are 26 or older. And then it would still be available to what we call our transition age youth or transition TAY population or younger. But once again, if that is what is clinically determined would be the best care for that individual. Next slide. And so this is just a visual of what we are proposing to be the adult FSP level of care framework. So you will see here, as I just mentioned, level 2 would be that ACT and or FACT, depending on the individual's need. And then level 1 would be that FSP intensive case management. So both of those could be funded under full service partnership, under that 35% bucket, under BHSA. But then as individuals go through that ICM model and then need to step down, they could then be stepping down into outpatient, especially mental health services. And that is if they no longer meet that need for that ICM services, and that is clinically determined, they could move into outpatient, especially mental health services. That step down would be then funded under that behavioral health services and supports bucket. Next slide. And as we just talked about, that high fidelity RAP model, while we are requiring that as an evidence-based practice and done to fidelity, in our research with subject matter experts, they do not support defining multiple levels of care for children and youth. Because high fidelity RAP, the way the whole service is designed, it really has that flexibility built in to adjust to that level of intensity according to the individual's need. Now, the legislation does not prohibit counties from establishing FSP programs for children and youth that have multiple levels of care based on that intensity. However, DHCS is not going to require counties to have multiple levels of care, but they will be required to have high fidelity RAP, and it will need to be done to fidelity. Next slide. So just really want to hear your feedback on the proposed levels of care. I think and we want to hear your feedback on the adult levels of care and then our proposal around utilizing high fidelity RAP as the level of care for children. So maybe if my team could just move us back a few slides that just shows the infographic of the adult levels of care so folks can see that's great right there. So just opening it up in the Q&A. If you have any comments about the adult level of care framework, and then also any comments around utilizing high fidelity RAP and not having like a level of care for our children and youth. So one comment here, just concerns around any sort of any potential fragmentation of services for individuals. So they're suggesting that for an FSP team, just really recommending that those levels of care are in the same agency with integrated teams in order for the individuals to really seamlessly go from one to the other without entirely changing teams or agencies. Next comment to need to think through the transitions of care as the ICM level and step down to outpatient can cause disruption for the individual being moved around, whether they're being moved around between providers and programs, as typically multiple providers may be involved.
There are multiple comments about there needing to be warm person handoffs from one level of care to another. And for those movements to feel seamless for the consumer.
Also, just comments to ensure that if somebody has, let's say, stepped down from ICM into outpatient services, that they're able to step back up into ICM or act in fact if needed. Yeah, lots of just comments echoing what I just stated about because recovery is not a straight line, just really ensuring that there can be fluid movement in between the different levels. Also, just some questions in about where individuals with serious SUD conditions can access FSP. I know there were some earlier slides on that about integrating that into the FSP team model. Um, and so that is something, and of course, obviously, these models here include co occurring as well. So a lot of agreement around having the continuity of care, especially mental health and ACT and FACT and ICM um, within the same agency is just a lot better for the individual that's being served. And kind of on that same thought is having a single point of contact in FSP and these programs. And then also just ensuring that there's outreach and engagement built into these models. Um, should also be allowable as a standalone service for very hard to engage individuals because engagement into FSP or ACT may take many months or even longer. Also, a lot of comments, making sure it's really clear with the high fidelity wrap, exactly what populations are required and or if individuals through like TAY could be eligible as well, making sure that that's clear in our guidance. Also, for individuals that may be using these services that have a substance use disorder, what that step down model would look like for them as well. Great. Well, I am going to move us forward in our last slides. So just really want to highlight, I hope all of you already know this information, but in case you don't, this provides information on our website around behavioral health transformation. We also have updates that you can receive if you want to sign up for those. We have lots of information on like FAQs, we have infographics, fact sheets, we have some timelines. If you haven't seen that, those are posted on our website, and we're frequently updating our website. That also is where we will be posting the information here, the slide deck. We're in the process of getting that up and ready for you folks. So you can look at all these great links. Also is our BHT inbox link is there. It's right here as well in case you need that. And this is for any sort of feedback or questions you may have. It doesn't have to just pertain to full service partnership, but anything around behavioral health transformation. And then as a reminder, our next public listening session will be November 4th, and that will be on that behavioral health services and supports bucket, that 35% bucket. So if you're interested in that, please register for that and we will see you then. So thank you all so much for making the time to be with us today and for your valuable feedback. Have a great day. Bye-bye.